Good evening, everyone. My name is Daniel Pohl. I'm the treasurer of the European Society of Neurogastroenterology and Motility, and it's my pleasure to welcome you to tonight's second webinar that we organized together with a Brazilian nucleus association for this study of Helicobacter pylori and microbiota. So we have two speakers tonight, and we will do two presentations, and after each presentation we will have time for discussion for after 10 minutes, and then move on to the second discussion, and then have questions at the end again. It's my pleasure to introduce our first speaker, which is Daniel Antônio de Albuquerque Terra from Belo Horizonte, Brazil. He's a gastroenterologist who's active at the FMT Center of the Alpha Institute of Gastroenterology at the Federal University of Minas Gerais. And Daniel will start to explain to us the rationale and the mechanism of action of FMT. Please, Daniel.
Thank you, Daniel. As you know, recurrent C. difficile infection is the main indication for FMT. And is indicated by several guidelines as a treatment of the second recurrence of CDI, or in special situations such as a severe CDI episode. But why it is indicated just after the second recurrence? The first reason is this. After the second recurrence, the patient is under the influence of self-perpetuating cycle of dysbiosis. This antibiotic itself, just as vancomycin, used to treat the CDI episode, is capable of maintaining the dysbiosis cycle. It is not to spontaneously recover the microbiota, so an external intervention such as FMT is needed to directly restore colonization resistance by introducing a whole microbiota community and indirectly modulating the host immune system. The other reason is that one. The second recurrence is the patients under the second recurrence is with high risk of another recurrences. So after the first episode, adequately treated with vancomycin or even with metronidazole, the chance of recurrence is 25%. After the second recurrence, the chance increases from 25 to 55%. The mechanisms of this is not due to antibiotic resistance, but to the inability to recover spontaneously a functional microbiota to prevent the colonization and germinations of spores. A patient with recurrent CDI present profound alteration in their intestinal microbiota, creating an environment favorable to develop of the C. difficile. Comparing to control group with initial C. difficile infections, and the group with recurrent infections, patients with multiple recurrences have a fecal microbiota with a marked reduction in diversity and richness, a low relative abundance of firmicutes and bacteroidetes, and a relative increase in pathobiontic strains such as a proteobacteria. They also have depleted of short-chain fatty acid producing strain, which indirectly decreased the mucin production and limited bacteriocin-mediated colonization resistance. Another reason can be seen here. Patients with high abundance of enterobacterial acid after any treatment that use antibiotic are more likely to develop recurrent infections. Increased relative abundance of enterobacterial acid is a predictor of decreased secondary bile acid production, and this creating a favorable environment for C. difficile spore germination and toxin synthesis. The traditional FMT transfer a wholly processed donor stool, and that includes not only microorganisms, which represent almost 50% of the solid material, but also colonocytes, mucus, immunoglobulin, and metabolites such as lipids, dietary fibers, fatty acid, bioacids, short-chain fat acids, et al. All these compounds together, and these include the non-live metabolites, can restore chromosomal community structure, can restore the functional deficiencies, and modulate several components of the immune system. This is a study that exemplified this. Is a small cohort of 5 recurrent CDI patients. They were treated with sterile fecal material. The substrate didn't have intact bacteria, but virus, especially bacteriophages, proteins, metabolites such as butyrate, and even DNA. Note that the same virus profile was found in donor, in the sterile filtrate, and in the patients after the treatment. The result was that all patients achieved clinical remission. This find indicated that the metabolome or even the virome mediate many of the effects of FMT. The exact mechanisms of actions of FMT are not well understood, but the potential mechanisms include competition between donor and recipient gut microbiota to achieve homeostasis, by competition for nutrients, or by release of microbial products such as adaptogens, bacteriocins, that will inhibit the vegetative forms of C. difficile, or by producing a proteases that will cleave the toxins already formed. Another effect is the modulation of the recipient, the host, metabolism and physiology. One example of that is the increased production of secondary bile acid that prevent the germinations of C. difficile spores. FMC is also capable of modulating the recipient, the host, immune system, activating different immunological pathways, such as increasing productions of interleukin-10 by T regulatory cells, reducing the activations of inactive immunocytes, and normalization of Th1 and Th17 cell frequencies. Now, talk about a little about our initial experience. In November 2017, our FMT center was structured at our hospital, dedicated initially to treat patients with recurrent CDI infections. In Brazil, as in many other countries around the world, there are no specific regulations of FMT, so this center was set up under the structure of the Tissue and Tumor Bank as a biobank regulated by national resolutions. It was a study published by our team. In 2020, we published the initial results of our patients. It was a single center pilot study, but it had a national impact in which 91 patients from 17 states, Brazilian states, were evaluated. Of these 91 patients, only 10 met the eligibility criteria for treatment. In addition to the diagnostic confirmation, we also analyzed the antibiotic sensitivity and the ribotyping of the identified C. difficile strains. All procedures were performed by colonoscopy, and until now, we have treated 17 patients. The majority were women with a median age of 65 years and a median of 3 recurrent CDI. All cases used antibiotic before acquiring CDI. All cases were treated with vancomycin and metronidazole, and all isolated strains were susceptible to vancomycin and metronidazole. And even that, they had a multiple recurrences, even with this profile of susceptibility. Our primary resolution rate was 88%, and overall resolution was 94%. Both rates are similar to those observed in other study. Current, our median follow-up is 45 months, and no serious adverse events have been reported until now. When we evaluated the bacterial microbiome change after the FMT, it is possible to observe that there was a significant increase in alpha diversity, numerical diversity, that remained high from 1 to 3 weeks after the procedure. The main relative increase occurred with the firmicutes, accompanied by a relative reductions of the proteobacteria in the responders. These were the 5 main genera that had a significant increase in abundance, all related to a greater productions of short-chain fatty acids and consequently a high production of butyrate. This change persists for up to 3 weeks, and the genera Ruminococcus and Faecal were those that remained elevated for the longest time and are markers, a predictor of a microbiota recovery. That's all. Thank you all for the attention.
Thank you very much, Daniel, for this concise overview and your personal experience and that of your center of FMT. You showed us
small experience.
Yeah. So tell me, how many centers are there currently in Brazil that give access to FMT?
As I know, ours is the only center with freezing stools, and around more than 100 patients have already came to us to evaluate the eligibility, but we have difficulty to obtain diagnosis. The most of these patients don't have the confirmation, and when they send the stools to us to test, already using antibiotic, all tests are negative, and we don't met the criteria for recurrent CDI.
Yeah, I saw your list that you said I think you had 91 patients, out of which you included basically 81, right? When you did your first 10, I believe. And if I looked at the indications, then there were some indications for which FMT is actually in research. Like there's autism was at the bottom, for example, as one of the things that were some data available on that. So I suppose that your center was in the media, and a lot of people tried or this is the only reason why I understand that you have such a high screening rate for C. diff, but so few who actually have it.
Yes, I don't know how can I say, but a lot of mothers of autism, spectrum autism, have send email for us trying to treat this child with FMT, but without a hard indication.
Yeah. So you said, I think if I understood you correctly, that currently there's not a real official regulation of how to do and when to do FMT in Brazil. Please correct me. So tell me, how is that currently done? And I understand you guys have your own procedures. Did you adapt this from anyone's procedure? And do you only use it for recurrent C. diff? Your patients had a median of 3 recurrences. You showed us the data that suggests that after the second recurrence it actually makes sense. So tell me a little bit about that.
We don't have a regulation for FMT here. So we decided to make FMT under a scientific study, approved by the ethical committee of our university. So we can do that because we develop a scientific study, and we structure the center into a biobank that we have a Brazilian regulation for a biobank. So we use these two strategies.
Okay, does this also mean that you have no reimbursement for the procedure?
I'm sorry?
Does this also mean that you have no reimbursement for the procedure? I mean, I'm thinking, Brazil is a big country with a lot of people. Now, there's one center in this whole big country that currently offers FMT, if I got you right, and if that's what you say is right, if there's no one in Sao Paulo or in Rio who doing it, right? And so my question is, what limits the access? And one of the limitations to access is usually if there is, number one, of course, no regulation, and secondly, if there is no reimbursement, if there's no money paid, or if there's no code for.
No.
How do you deal with that? And I know you do it under study.
It's free. We have a unique system of health in Brazil, and the patient just have to pay the travel to come to us, and here they could be in our hospital with all paid for the patient. Only the travel they have to pay, but the FMT and all the healthcare it paid by our insurance.
So, Gianluca, if you're there, can you tell us a little bit about how things work in Italy? How long you've been doing FMT reimbursement standards? Because I know in Italy the programs have been going on for some time. There's also a number of centers involved. Eduardo shared his experience, Eduardo Savarino, in an earlier talk. So please give us a little bit of your Italian experience.
Yeah, sure. Let's go in a timeline. Basically, my center started FMT in 2013, so 11 years ago, almost 12. And basically, since then, we were the first one, and for a long time, we were the only one center in Italy. But basically, at that time, FMT was not regulated. But finally, the Italian National Transplant Center put the FMT under its umbrella. So FMT now in Italy is considered a tissue transplant. So microbiota is considered a tissue in Italy and not a drug, a medicine, or whatever you can find in other countries. After that, they had a program. They launched a program to basically regulate the provision of FMT in Italy and to have an accreditation of different centers. So they were around Italy basically to make some audits to say you can do the FMT and you cannot do the FMT, checking all the facilities for each FMT step. So microbiology, so clinical unit, endoscopy, and so on. And then other centers like Eduardo, like Giovanni Barbara, and others joined this program, and they are working now. So I think Italy in Europe is one of the most present countries for FMT.
Very nice. Yeah, so I mean, the main
reimbursed.
points that you said were that I guess that at some point you had also some health authority input, right? And then you had some sanitizations. People centers were being visited to see that they actually do what is a common standard, a common accepted standard, right? It's also an interdisciplinary thing, right? You said you have microbiologists that you need to perform this, and then in the end, you also had had a specification that this was now not nothing or a drug or even a technical implant or whatever. I mean, there's different ways, right, to talk about this, but that it was actually tissue and that you also have a billing code. So how much do you know how much you can bill for that? Is this all inpatient based? Is there also a role for ambulatory, or is it purely inpatient based? And is it under your regular insurance code, or how's that working?
So basically, usually the FMT is not regulated, is not reimbursed, and it means basically that you're reimbursed just for the colonoscopy and for the donor screening, because all the fecal donors belong to the classical tissue donors, like kidney, for example. So you can get reimbursed this way, but you are not reimbursed for the procedure.
Okay.
But the real gain is that you prevent the hospital charging, and in inpatient, you basically reduce the length of stay and increase the overall survival. So this is the real gain, actually, even if it's not officially reimbursed. And another point is that we do inpatient and outpatient, but mostly are outpatient, at least in our center.
So, Gianluca, what do you think? How many people who have a recurrent CDI in Italy actually do get access to an FMT after, let's say, at least the third recurrence? Because I suppose that most people do not get one after the second, unless they come from a center city.
We have data not specifically from Italy, but from Europe, from a survey that we did, and usually it's 10%.
10%, huh?
Yeah.
So even in a country where you started, you said 11, almost 12 years ago, still the big majority of patients do not have access to what we, I think, all agree is also from a mechanistic standpoint the most currently logical way to treat this severe disease, correct?
Yeah, exactly. Yeah. Basically, because most of these patients are managed in pediatric units in non-academic centers, and usually all the FMT centers are from academia.
Okay. All right. Also, if there's any questions in the audience, please feel free to write those into the chat, and then I'll take those. So I think if you're good, then Gianluca, I would like you to talk a little bit about the clinical applications of FMT. Generally, you're from Rome, Italy. Thanks again for joining us at this rather late hour from the European side, but you told me before that you're a late night worker, so I don't feel so bad that we involved you, but thanks again. And yeah, looking forward to hearing your talk. And then Daniel, and also please all the other people who are joining, happy to discuss this.
Okay, so thanks for the invitation, and we will discuss here what FMT can do in clinical practice. So we will not deal with the future and research application for FMT, even if they are really interesting. And hopefully this kind of talk will be expanded with the other indication in the near future. But at the moment, we have to remember that C. diff infection is the only indication for clinical practice for FMT. Basically, the rationale of FMT is that we have an healthy microbiota, some stressful events of life, unhealthy diet, the use of drugs, systemic disorders of stressful events, drive to dysbiosis that can drive to that contribute to several disorders, And by FMT, we aim to reconstruct the healthy microbiota to give a contribution to the global health of the individual. I remember that we have three main steps of the FMT: the donor screening, the preparation of the material, and the delivery. The screening means that you start with a questionnaire to rule out basically everything that can harm the recipient. So infectious disease and related risk factors, the use of drug that can impair the microbiota, or disease that can impair the microbiota, so that can transfer an impaired microbiota. Then blood and stool exams to exclude transmittable disease, and at each donation you should have a questionnaire to be done before donation to exclude any issue risen during the screening. And then you have also the possibility of a molecular testing on each stool batch, or a quarantine to be sure that there are no issues in the patient arising. The preparation, we have two main formulation, which is the fresh formulation or the frozen formulation. There is also another option, which is the lyophilized material, but it's just for research now. At the moment, we can say that you can use a fresh material just if you have a small FMT center, but if you have a large volume FMT center, you have to go basically for sure for frozen material, because otherwise you will not able to satisfy all the requests. Finally, the patient can receive FMT by several routes of delivery, including the nasojejunal or nasoduodenal tube. Usually the nasogastric tube is not recommended anymore, by capsules, by colonoscopy, or by enema. We know, as I told you before, that FMT has been accepted very rapidly, I have to say, as a treatment for recurrent C. diff. And why C. diff? For three main reasons. An ecological reason, because the C. diff infection is a very simple model of dysbiosis, with a drop in microbial alpha diversity, with a persistence of few aggressive pro-inflammatory bacteria that are the only one that can survive into this harsh environment of the C. diff colonized gut. So it's very easy to restore. This is why FMT works in C. diff. The other reason is epidemiological, because FMT has popped out when C. diff infection was a very, and is a very burdensome disease. When I was a student, I have probably seen one patient with C. diff in the whole medicine course, and also in my handbook of gastroenterology, it was very, very neglected. There were just few lines. But mainly for the use of antibiotics, the overuse of antibiotics, now the C. diff infection is rising. And these are data of 10 years ago. In the US, you have every year 29,000 deaths, 5 billion expenditure, with an increase not only in the incidence of new cases, but especially with almost 200% in the incidence of recurrent cases. And this is critical, because recurrent disease is more likely to present with a severe clinical picture, because they resist to antibiotics, so the disease can grow on a biological point of view. Another reason is clinical, because FMT has changed the natural history of C. diff, because it's much more effective than antibiotics. Basically, we know that FMT decreases the risk of bloodstream infection and increases the overall survival in recurrent CDI. Especially in this paper, we showed that you have a decrease in 4 times in the rates of bloodstream infection, a decrease of 50% in the length of stay, and an increase in 30% in the overall survival. Basically, it makes clear why having an FMT is cost effective, regardless of the reimbursement. For these reasons, FMT has rapidly become an established treatment for the management of recurrent CDI, especially in the last 10, 15 years. FMT has been embedded in all the guidelines, international guidelines for Clostridioides difficile infection, and we had also several consensus reports on FMT and stool banking. Just one indication which is very close to C. diff is the multi-drug resistant pathogens. It's also another burden given by antibiotic resistance. And at the moment, we have several case series and case reports, but no randomized trial yet. As I told you before, during the discussion, FMT is still under diffused in Europe. At the moment, we have in Europe 31 FMT centers from 17 countries, with nearly 10% of patients benefiting from FMT. But the white side of the coin is that all the centers were very adherent to international guidelines, and they were all academic, basically. So basically, we need this gap in coverage, suggests the need to raise the awareness and to increase the FMT activity in the development of FMT centers in Europe. But we have still some barriers that prevent the diffusion of FMT in clinical practice. The first one is safety, because FMT has been alerted by the FDA to have a potential risk of transmission of multi-drug resistant bugs. Together with the other colleagues, we have had a letter of response in Lancet Infectious Disease some years ago, showing that all the major stool banks and FMT centers have screening protocols that are able to prevent the transmission of multi-drug resistant bugs. And we more than 45,000 FMTs all over the world, we hadn't any serious adverse events. So the adherence to standard screening protocols are the key to prevent these issues. We have some other obstacles beyond the safety, including the lack of the dedicated center, because believe me, it's very tough to build up an FMT center. Also, the bureaucracy can be tremendous, and also the donor recruitment is critical, because from 3 to 10% of donors are basically of candidate donors are basically pass the screening. The other 97% do not pass. But FMT is a necessary treatment for these patients, so we need some solutions. One solution can be the stool bank, because the stool bank can guarantee the safety, can avoid the need of dedicated center, will deal with bureaucracy, and will basically have a continuous donor recruitment to avoid any shortage. We have some guidelines that basically launch and regulate the stool banks, but we have also another solution, and the solution can be the FMT 2.0, which means that the so-called fecal microbiota transplantation 2.0 or artificial FMT, which have some bacterial consortia from industry. We have two main products that are approved by the FDA since 2022, 23 for the treatment of recurrent CDI. So basically, they are another possibility to basically overcome all the practical and logistical issues that are associated with FMT. And I'm going to conclusion, we have also a cultural issue. So at the moment, we have a gap between the basic scientists that deal with microbiome and the clinicians that deal with microbiome. So it is a time to build a translational figure, the so-called microbiome clinician, which is a clinician that is also able to understand the microbiota profiles and modulate it very precisely. And I'm going to finish. I'm very happy to speak with the Brazilian Helicobacter Microbiota Study Group, because at the moment I am the president-elect of the Helicobacter and Microbiota Study Group in Europe. So I'm happy, even if I'm invited by the ESNM, I'm happy to invite you to the next workshop of our society that will be held in Rome in September. So thanks so much.
Thank you, Gianluca. That was very interesting. Share your longer experience and also yeah, it looks like this is something that we already discussed earlier. The access is an issue. Right? If you say that if you looked at your European data, that you estimate that approximately 10% of the patients who would need an FMT currently have access and perform one. So do you see that in the past 2-3 years this is changing? Do you see a rise in centers doing this? Do you see a rise in the numbers?
Well, I believe that basically FMT is not scalable in a large scale unless we basically involve non-academic centers and but you mean it's a long way to go. So I don't know if there will be more centers popping out once the bacterial consortia will come, because it's easier, obviously.
Yeah. How about that? I mean, there is number one, there's modern antibiotics which are being used in some countries, like fidaxomicin, correct? And then there is also the more commercial ways to give microbiome-related products, specifically the difficile or Microbiota, which was FDA approved, I think in late 2022. I
Yes,
think it's still, yeah, that's correct, right? I think it's still not currently approved by EMA, but you may correct me on that. And whoever, do you have experience with it, or do you just know it from the study data?
I don't know if it's in Brazil is already present. I don't know.
Daniel, is the Brazilian health authorities, are they FDA close or more EMA close, or actually do they go after the Swiss system, which some countries actually do?
We don't have yet.
Okay.
Eduardo Vilela could tell us better, but not yet.
Yeah. And there's currently, Gianluca, are there any other products in the making? I'm sure, I mean, I know there's other substances which are being tested, but currently it's the only FDA approved one. Is that still correct?
No, FDA approved 2 or 3. Probably if there is a third one, is very recent. For sure, there is another 1 or 2 in Australia.
Okay. I have a practical question from the chat. And that goes to both of you, how you feel this is true. How long can you store the frozen feces? And adding on to that questions, under what conditions do you freeze it? Do you freeze it -20, -80?
-80, there are some reports for up to 2 years. Usually we do for 1 year in Italy.
Right. And Daniel, I think
Here
you have a
here
stool
to
bank.
up to 6 months and under -80 grade.
Okay. I mean, in theory, using a -80, you could probably do it even much longer, correct? I mean, it's probably a rather arbitrary number to do 6 months or 2 years. But okay, so we hear that. And but Daniel, you could use it longer. I mean, you said there's no regulation in Brazil. This is just what you and your center do, correct?
We use until 6 months. After that, we use another fecal microbiota prepared. Our limit is 6 months.
Yeah. So Gianluca, what's your preferred route of delivery? And how do you decide? I mean, obviously there are centers and availability, but I mean, a lot of these centers who do larger numbers, they can choose what they do. So what do you think is the way to do it?
Well, in Italy, the only way in clinical practice is colonoscopy. Colonoscopy is a good way to, because you are able to even explore the large bowel and see if there are any sign of pseudomembranes, which means that this is a severe C. diff infection, and it means that you need repeat FMT schedule and not only one FMT. So these are the advantages of the colonoscopy. But if you consider, and I'm going outside clinical practice, if you consider FMT as a chronic approach, a chronic therapy for chronic disease like ulcerative colitis or others, or irritable bowel syndrome, basically you need some sustainable therapies. You cannot do one colonoscopy per week. So I think capsules are the best way. We are also investigating lyophilized capsules, but they are not approved yet. But I think, in my view, that one day we will use lyophilized capsules.
There's another study by Luis Guerra, and he's asking, is it necessary to test and treat for Helicobacter pylori in the donors?
Only if you perform an oral fecal transmission infusion, because if you do by colonoscopy, there is no need, because H. pylori is not able to survive in the large bowel.
Yeah. Okay, so it depends on your route of admission.
Yes.
Do you ever do small bowel? I mean, if we can discuss this in a second. You know, outside indications of FMT, and there's interesting data from Norway, you know, where they did small bowel infusions in patients with IBS, and they had excellent results, much better than all the results you see from other centers. This is Magdi Azai's work. And one of the things that was interesting, if you looked at the study, was that the people who received the FMT, they had a lot of side effects. They basically all had a small enteritis. It looks like to me, right? And possibly this is also important. and
yeah.
For the effect. So what's your take on this route, on the small?
I totally agree. I believe that, for example, FMT, if given by oral delivery, you know, upper delivery, can even bring you to small intestinal bacterial overgrowth. So I perfectly agree. Basically, there are now some capsules that open in the distal ileum, and I think they are the best.
yeah, we are waiting for data, right, to see that. But in theory, that should help. Although, I mean, the microbiome of the small bowel, especially the distal small bowel, is a highly interesting topic by itself, right? And it's still a black box to us. And again, the data for IBS actually suggested that if you involve the small bowel in the infusion, that it's actually beneficial. Maria is asking a question. Maria Sana is asking, how many sessions do you perform per patient by colonoscopy? Probably she refers, or probably she asks, how often do you have to do this colonoscopy?
Well, for a mild C. diff infection, usually it's we repeat it every 3 days until the disappearance of the pseudomembranes in people with severe C. diff. In people with mild C. diff, usually one is enough. We repeat if there is a recurrence, but otherwise one is enough usually.
Daniel, what's your experience?
Gianluca, and you repeat the bowel preparation after three
No,
days?
if there are 3 days, we don't repeat. If there are 2 days, we don't repeat. If there are 4 days, we repeat a small one.
Okay, and you don't maintain the antibiotic treatment?
Yes, we maintain the antibiotic treatment, the vancomycin or the fidaxomicin, depending on the case.
Okay. Here we just do one colonoscopy, procedure with colonoscopy. A single infusion it was successful in the most patients.
And
yeah, I know.
do you pre-treat?
Our data show that in the severe patients, you can have a gain in 30% of the cure rates of CDI if you increase in the doses, the number of the infusions, but only in the severe patients.
So these are the life-threatening cases that you're talking about, right?
Yeah.
The normal ones, if I look at our response rate with singular infusions, they are well above 90% in a singular infusion, also done by a colonoscopy. And Daniel, how do you pre-treat your patients? I mean, obviously they are recurrent, we understand that, so they have had other antibiotics. But let's say you schedule a patient for an FMT. Do you give them a 7 to 10 day course of vancomycin or something else before? How do you do that?
Yes, usually we use 10 to 14 days of vancomycin, and after 25 hours to withdraw the antibiotic and do the bowel preparation through the colonoscopy. 10 to 14 days, depending on the schedule of the endoscopy center.
All right, so you stop the antibiotic the day basically before you give the infusion.
Yes.
Okay.
Yes.
And Gianluca, do you also in the mild cases keep the antibiotic running, or do you do it similar to Daniel?
No. In the mild cases, we keep it until the day of the transplant, then we take it off.
Okay. I see. It's always interesting to see how centers do things differently. Yeah. So what about? I mean, Daniel, you said, or also Gianluca, you said that currently, I guess in most countries, the only approved or accepted way of or indication for FMT is the recurrent C. diff. But also, obviously, there's also other indications. Could you comment a little bit on your view on the current state of the art? You know, what's promising? Where do you see a role in the future? other indications than C. diff?
Well, we had very nice data on chemotherapy-dependent diarrhea. And also, we are having some nice data on the colitis from induced by immune checkpoint inhibitors. And also, we have a randomized trial that is ending. The preliminary results are good, but let's see what happens with the full sample. But our preliminary results suggest that FMT may be useful in increasing the response to immune checkpoint inhibitors. So probably,
sorry, I didn't hear that.
the increasing the response in immune checkpoint inhibitors.
Yeah.
So probably this could be probably the most in multi-drug resistant bugs. These two, so cancer and multi-drug resistance, I think they are the main fields for FMT. Because while other like metabolic syndrome hasn't given very good results. For ulcerative colitis, I believe that we should understand in which patient, as well as in IBS. In IBS and IBD, we don't have the same importance of the microbiota from the pathogenetical point of view. So I believe that we should identify the patients that are able to respond to FMT and those who are not. Because they are both some umbrella disease.
Yeah, that's true. Speaking of mechanisms, or taking up this point, also Daniel, to you. I mean, Gianluca, you showed how the rise of incidence of recurrent C. diff. And mechanistically, you both mentioned each a point. And one is the disturbances of the microbiota, which is in recurrent C. diff so severe that the body may not be able to restore the microbiome, even with the help of antibiotics. And it's not such an issue of actually that using antibiotics, you're not killing the C. diff, but rather that the surrounding microbiome is so disturbed that you don't get back to health. On the other hand, Gianluca, you said we have a rise in, I mean, and this is true for all bugs, we have a rise for multi-resistant bugs, right? And microorganisms, all kinds. But what is the real deal here? Is it the problem that our antibiotics don't work, or is it really that the things that we are doing to our patients disturb their microbiome so much that is the main thing?
Here, all our strains are susceptible to vancomycin and metronidazole. So even the patients using this kind of antibiotics, they develop a recurrent. And so we believe that in our case, the dysbiosis, self-perpetuating cycle of dysbiosis is more heavy to the factor that how can I say? It's more the main factor that that the microbiota can't recover itself.
Yeah, so Daniel, you're saying the main thing is not the antibiotic resistance,
Resistance, yes.
Inability of the body to restore the severe dysbiosis. Gianluca, what's your take?
I totally agree with Daniel.
Okay, that's good. So why are we seeing so much more C. diff? And what can we do to actually prevent C. diff in the first place?
Basically, reduce the antibiotics by measures of antibiotic stewardship and by basically raising the awareness for a healthy lifestyle, less unnecessary drugs, a healthier diet, a healthier lifestyle. This will build your microbiota and then will prevent you to develop C. diff.
So Daniel, do you also see a rise in incidence of C. diff in Brazil? I know you look like a young colleague, so I don't know how long you've been in practice, but how do you feel? What happened in the past 5 years or maybe 10 years regarding C. diff? Is it an issue which is as grave as we just heard, where it seems a disaster in the United States with, I think, 29,000 deaths, Daniel, Gianluca, if I quote you correctly. So what's going on in Brazil? Is this also sharply on the rise?
Unfortunately, we don't have the exact data of epidemiology. Eduardo Vilela has conducts a study in our hospital, and he can tell us more about that, but the exact number of epidemiology in our country, we don't have these data. So a personal impression is that the number of diagnoses is increasing, especially in our hospital, but the epidemiologic data we don't have yet.
Yeah. Okay. This was very nice. If there are any more questions in the chat, I think we answered all the 3 questions that we got in the chat. And Daniel and Gianluca, if you don't have any more pressing issues, then I think we'll come to a close here. Thanks both of you for sharing your personal insight of what's going on, not only in your country but also across the region. Daniel, keep it up. You are the only center currently, and I think you have a model function in Brazil. And I hope that when we talk again in a few years, there will be other centers joining you. And well, Gianluca is now the president-elect of the society in Europe, so it's up to him also to shape the future of things in Europe. But yeah, I think we learned a great deal, and also thank you for the practical questions from the audience. So and I wish you all a good evening. Thanks for joining. Thanks for watching, both from the ESNM and the Brazilian Nuclear Society. And have a good pre-Christmas time. Thank you very much.